Hello, I'm Manoj Karmakar. In this next video, Dr. Amitabh Gulati from the Memorial Sloan Kettering Cancer Center in New York City is going to be discussing with us the role of peripheral nerve stimulation for the management of chronic pain. If you like any of our videos, do remember to like and share it with your friends. Also remember to subscribe so that you can get regular notifications of any future uploads. So now enjoy the upcoming video.
Thank you very much, Manoj, and all the group that's been arranging this is a wonderful program. I just want to make sure everyone can hear me okay and see the slides.
Yeah, very good.
Perfect. I have a few minutes to chat about peripheral nerve stimulation. And unlike some of the other topics you had earlier, especially the last one, our research in this field is not as robust. More importantly, different countries have different access to devices. So in my experience with what's available more in Asia, it's probably not as robust as what is available in the United States and in North America. So I will be, when I come to devices and things like this, I'll be more focused on what's available in our country, but I'll try to keep it as basic as possible so you can translate the information to whatever is available in your side of the world. These are my disclosures, and clearly I keep this as non-partisan as possible, given that some of these companies are working with peripheral nerve stimulation. While I am talking about chronic pain, there is some excitement about acute pain management with peripheral nerve stimulation in the United States, so I'll spend a couple of slides on this, but I'll really focus on chronic pain management, the evidence, at least in our literature, and then how I've used some of these devices in clever ways for cancer, because I am at a cancer institution in New York City. When we think about peripheral nerve stimulation, we think about what the devices are doing. And that has to a little bit understand what the devices are. So for example, you can have a battery and then a wire to the nerve, and that end of that wire can have a contact or multiple contacts or a lead. I'm going to talk first about having one contact or multiple contacts that act like one contact at the end of a wire, and that will be a positive or monopolar stimulation pattern. So it's very important to understand. We're actually, when these kinds of leads, these monopolar stimulators are in contact with a nerve, they will activate a nerve. And so when they activate a nerve, they're given a frequency similar to a TENS unit. Low frequencies, 6 hertz, 10 hertz, 12 hertz, can activate a nerve or neuron to activate a muscle contracture. Higher frequencies, 50 hertz, 60 hertz, 100 hertz, 120 hertz, you'll have to feel something. And it could be a sensation that's butterflies, it can be more painful. So depending on some of the other variables for a stimulator that you set, you can cause a feeling that's comfortable or activate even your pain fibers with enough energy, so to speak. In our country, we have 2 devices available. We have a permanent system available and a 60-day treatment available. And both of these devices, the energy is externalized. So in other words, the wire is in the skin and either comes out of the skin and attached to a battery on the skin, or the battery is attached to the skin and sends energy through the skin to the wire. The wire has a receiver or a rectifier that takes that energy and makes it into the frequency and the waveforms that you are trying to implement. What's most important here, we're using these monopolar stimulation patterns, is that there's what I call a sweet spot, a distance away from a nerve or a fiber that seems to be a more ability to activate your sensory fibers before you activate your painful fibers. The Holy Grail is really to activate your A beta fast-acting fibers. Those fibers you activate with the monopolar stimulation 10 microseconds, 15 microseconds, are more about feeling something comfortable. So something that pressure, butterflies I've heard, those kind of sensations before you activate your A delta fibers, which would be more painful, burning and gnawing. That magic depth in the world of modeling for peripheral nerve stimulation tends to be between 1 and 1.5 centimeters. And so our hope is that you can use something like ultrasound to see a nerve and to place a wire closer and closer to that nerve. And when you activate it, you have some sort of pleasurable feeling before you have a painful feeling. It's my experience that the smaller the nerve goes, so the closer and closer that wire has to get. So my experience with, say, the sciatic or popliteal nerve is that 1 to 1.5 centimeters may have some differentiation between A beta and A delta fibers. But as the nerve gets smaller, such as the saphenous nerve, the closer most of these contacts have to get to activate the nerve before they make a muscle contract, because on the way to nerve, you may be able to contract a muscle as well. Our first trial available in the literature was Dr. Deer's trial in 2016. It was really taking the permanent monopolar system that had three small contacts and would be a positive current and the external battery on the skin, using radio frequency technology to get through the skin and into the receiver. The studies looked at all neuralgias, so not just one specific nerve injury, but traumatic or post-surgical nerve injury with a crossover. So everyone received a device, and then 90 days, other the patient, the people who did not who got the sham study got the real device. And then we looked at the pain scores. Looked at is a randomized controlled trial, and really the goal was safety first and efficacy second. And what you found was that in 45 patients and then 49 patients in the control group, you found that patients had 30% of pain relief, and in the treatment group was 30% of the patients, and 3% of the patients in the control group. And this was exhibited also in the crossover. So the earlier studies really showed 30% improvement in 30% of patients. These devices were placed by X-ray or ultrasound or anatomic base, so there was some variability on the distance away from a nerve. But the most important take-home point in this study was that the safety, the serious side effects related to the device were zero. Why is that important? Before this time, people were using spinal cord or dorsal column stimulators as peripheral nerve stimulators. So devices designed for the epidural space were being implemented in the peripheral nerve space. Occipital nerve is a great example. And what you would find with these devices was that they would break, they would get infected. They had to go to multiple locations to implant the internal battery. And so there's a lot of side effects. The decision to make dedicated devices for peripheral nerve stimulation has significantly improved the side effect profile. So the things I see now are rashes, maybe a little bit of heat at the site of an external battery. And those devices that were breaking and getting infected are not being seen at nearly as high of a frequency as we did before. Kind of one of the unique devices we have available in the United States is not a permanent device, but a 60-day treatment device that you remove after 2 months. So this concept is following similar to acupuncture, similar to TENS units, where you put on for a certain period of time, 30 minutes, 1 hour. You take the pads off, and then you have a residual effect for a few hours afterwards or a few days afterwards if you're using acupuncture. Concept here is when you send a normal physiologic signal to a part of the nervous system that was having abnormal or lack of a signal, that normal signal that may interfere with the maladaptation of the brain. So now your brain can kind of remodel itself to more normal before the chronic pain syndrome happened. A lot of these studies are in these small animal model, rats, mice, but nonetheless, we're translating some of these ideas of remodeling the central nervous system by giving a normal signal for an extended period of time so that the chronic pain syndrome may dissipate once the wire is removed. This wire is a monopolar system. It's very, very small. So now we're talking the same as a strand of a hair, a little bit thicker. It goes into the skin. There's a 1.5 centimeter active tip lead that's positive, The wire comes out of the skin and is attached to an external block directly, so direct DC current. We're not converting radio frequency or induction currents into a different field or different waveform. This is directly attached to a wire, like you plug in a computer into the outlet, as opposed to, say, taking energy from an iPhone charger, etc. The cleverness of these devices has allowed it to be used in regional anesthesia along with chronic pain. When it comes to regional anesthesia, a lot of this work is being done in University of California, San Diego with Brian Ilfeld, really looking at 3 different surgical subgroups, shoulder surgery, knee surgery, and then foot surgery, bunionectomy, they say. Now, the idea here is to see if regional anesthesia for these patients. So, for example, a patient would receive a interscalene catheter with local anesthetic, or an interscalene block with a peripheral nerve stimulator external implant for 14 days. And what we see is that the patients had significant pain relief at post-operative day 1, so not the day of surgery, but the day after surgery. And you see the significant pain that I'll show you in the next trial. That's a randomized controlled trial. But the early pilot studies showed that the pain relief was better than using the regional anesthesia catheters for 1 day and then taking it out. But also the use of opioids as post-operative pain significantly improved. So patients were not using opioids at day 30 or day 90 as opposed to historical comparisons. What you want to also talk about is some of the chronic pain syndromes. And so we have data on both low back pain or medial branch nerve, really at the end of the medial branches near the multifidus. We have data on phantom limb pain, and then we have clinical studies on shoulder pain and some other case series. But the most important is in in low back pain and in phantom limb pain. This study by Gilmore and colleagues, a lot of this work, early work being done in North Carolina, both for residual limb pain and phantom limb pain, PLP. We see here stimulation for 2 months, and then removal of the lead. And in 2/3 of patients, you have prolonged relief for up to over a year, up to a year in this patient population. So we have a significant number of patients in the 60% time and 60% range, and a randomized control trial showing that you have prolonged relief after removal of those wires, showing the idea that prolonged stimulation for 2 months can lead to even longer relief when the wires are removed. This is Dr. Ilfeld's now randomized control trial for acute pain. We see here that you have significance in superiority when it comes to using these devices versus sham. So all patients receive the regional anesthesia block for knee, ankle, or shoulder surgery. They have the wire activated in post-operative day 1. And what you see is that there's a significant improvement in pain control compared to the sham. So blue is sham and red is pain control. And by the 3rd day, you have very little pain in the surgical population, but you still have post-operative pain in the sham population. The worst pain is higher in the sham population, and the pain rating scale is higher. But the most important thing is that it looks like a peripheral nerve stimulator device can substitute and use of opioid in the postoperative 7-day period. So from day 1 to day 7, patients can rely on their peripheral nerve stimulator as opposed to asking for an opioid. And this is very significant. This is consistent with TENS units being used for closed surgery. So TENS units placed in a sternotomy, for example, you'll see patients' pain may be improved by 1 VAS or NRS pain scale score. But what you will also see is that the use of morphine in those populations has significantly decreased. So it is fairly evident that neuromodulation can reduce opioids in the post-surgical pain context. In the next few minutes, I'll talk about some devices not available in the United States. This is taking concepts a different way. So the specific device available in Europe really meant for the tibial nerve. So it's the device with an ankle external battery. The device is placed into the tibial nerve, much smaller now, not a real wire even. There's a contact almost, it's large contact. The frequency and choices are shown here. And initially, the case series is used for peripheral neuropathy from diabetic use or CRPS. What is interesting is that some of these devices are used in clever ways. So for those of you that are not acupuncturists or not aware, the tibial nerve is part of the bladder meridian in acupuncture, and the tibial nerve stimulation in urology has been used for bladder-related pain. The theory being that you can place a stimulator on a peripheral nerve to activate in a referral pattern almost on the spinal cord. And so we have to think very differently from a local anesthetic blockade than stimulation. Our purpose with stimulation is to have changes on the second order neurons of the spinal cord and maybe even beyond into the central nervous system. That means that any neurons that are next to the nerve that you are stimulating may also have changes. In this case, the sympathetic chain and well as the tibial nerve and the brain and the spinal cord. We can take the similar concepts of pancreatic cancer and T9, T10 area musculoskeletal, taking advantage of our understanding of referral patterns. So stimulators can be used in a similar way, not just dermatomal, myotomal, or neurotomal patterns, but also following visceral or referral pain patterns, as well as acupressure points. And then I'm going to transition to what's probably a little more known to familiar to all of us, which are multi-contact systems. They're more similar to a spinal cord system that have contacts that are roughly half a centimeter to a centimeter apart. And these devices usually have 4 contacts or 8 contacts currently. And those contacts are more cylindrical and a little bit thicker. And therefore, because of physics, the fields will be closer to the actual leads themselves. The cylindrical multi-contact systems tend to need to be closer to a nerve to activate it appropriately. Now, the interesting thing here is you can have both a positive cathode and a negative anode along those cylindrical contacts. It allows you to steer the field just like you would in a spinal cord if you had 1 or 2. But more importantly, it allows you to potentially reverse your polarity, meaning that as a sodium ion opens, it's positive and heads down a nerve, up a nerve, for example, you can put a very big cathode against the sodium ion chemical and electrical gradients and see if you can stop conduction and put a negative ion where the sodium channel opens, called anodal blockade. Regardless, these devices both have external and internalized batteries in the United States. They're currently externalized batteries, so the leads are placed inside the skin, but the energy source, the battery, is outside the skin and is delivered through the skin to the wire itself. What matters here is if you want to go a longer nerve, say a popliteal nerve, how does the orientation of contacts matter? Just to simplify such a complex slide, what we find is that putting the wires or contacts along a nerve allows you to either activate or to turn off a nerve anodal blockade with less energy than going across a nerve. So going across a nerve will require more energy for activation. Going along a nerve will require less energy for activation. So unlike a monopolar stimulator with a multi-contact system, you will be required to place it along a nerve for optimal use. Clearly with ultrasound and some other techniques, this may be easier, but there may be some nerves that are very circuitous or windy, and you may not be able to achieve this completely. Some of the internalized systems available with our colleagues in Europe. This is a device available in Italy and it has made its way through the rest of most of the EU. We have the 4-contact system shown here, and there's a large case series now, but really looking at nerve type pain syndromes, surgical pain, neuralgias of multiple nerves, even the glossopharyngeal nerve, brachial plexus, which I've commonly done, and then different neuropathies. Unlike the United States, these devices can be used for facial pain in Europe, so that's a little bit different. But using it externally around the facial bone structure to try to activate some of the superficial nerves of the face. Again, these devices have multiple positive outcomes, but again, these are not randomized controlled trials. We have another clever device in the United Kingdom. Now the multi-contact system. Now the difference here is a device specifically designed for the occipital nerve, and so it has a specific anchor to hold this peripheral nerve stimulator uh, from moving. Now, if, for example, I have a lot of issues with neck because of movement, they can pull a lead or even fracture the lead. So what you'll see most of these peripheral nerve stimulator leads being very, very flexible to allow movement. And then the second step will be putting an anchor of some sort on near the end of the contact so it holds it in place. And so this is specifically designed for the occipital nerves, available in the United Kingdom, and it's targeting cluster headaches. And now this is their own internal trial has been published, looking at reduction of cluster headache specifically, and a little over half of the patients have 50% reduction in the in the in the frequency, and a little more patients receive at least 30% reduction, and then the pain intensity decreased roughly 30%, and about a third of the patients. You can see that these are not 100% improvement in these systems, but it has been very helpful for at least half of the patients for a cluster-based headache. Another system available in the United States is is specifically targeting the medial branch nerve. It's also available in Europe and Australia. This is a design specifically for low back pain. And what we see is that in this device system, and I didn't actually put the entire randomized control trial here, was that with use of stimulation over time, you saw significant improvement in both quality of life, mobility, and in pain. So when you use low stimulation settings, not very high settings, almost subthreshold in some cases, you can see that this does not have a feeling necessarily, but with activation over time, you have improvement of pain scores and improvement of function. And that's what makes this device very unique for a significant problem around the world for sure, but in the United States when it comes to low back pain. And so we're using multi-contacts. You can take advantage of this from creating a large field to contact a nerve you have difficulty seeing, and also not knowing exactly the location, so you can activate along the transfer process shown here. Now, the case series and contacts, really looking at phantom limb pain from used large multi-contact devices. A lot of the work by Rick Rauch for phantom limb pain, taking the concept of multi-contact systems giving you residual relief after the removal of the device. So again, we see here 2-week stimulation of the sciatic or femoral nerve in 9 out of 16 patients. When the leads were removed, you had some recurrence of pain, but that improved over time compared to the baseline. Just showing that even with multi-contact systems with similar frequency and pulse width settings, you can have similar effects post procedure in terms of pain relief in devices that may be removed after 1 or 2 weeks. So we see that the idea can still persist even in multi-contact systems, but in most multi-contact systems that are available, they seem to be permanent implants with permanent type stimulation settings. And I'm sure I only have a few minutes left, so I'll go very quickly for oncology. We've really used these devices very cleverly. We've used the temporary systems, monopolar systems for acute cancer pain syndromes. Shown here is actually one of the best needles I've ever gotten. This is an unadulterated picture of the actual going through a pancreas tumor, a tumor of the lung hitting the brachial plexus. For a patient who could not tolerate opioids for pain control and who did not want a percutaneous cordotomy. We placed a peripheral nerve stimulator next to the brachial plexus, and she was able to get pain relief and actually was able to go to hospice and die peacefully while using the peripheral nerve stimulator until the very end, where she needed MRI, and this time the MRI, the wire was removed. So we have some clever uses of this for active spinal tumors, sarcomas of the leg in different locations. And one of the locations we were showing, I know you had a wonderful discussion on ultrasound and the use of targeting the selective nerve roots. It's an extraforaminal injection. This is almost an extraforaminal placement in the thoracic spine for the peripheral nerve stimulator. So we're capturing the thoracic nerve root here. And we do that for the lumbar spine as well. Typically do this under ultrasound or ultrasound plus fluoroscopy. We'll place these external wires into the right at the posterior lamina almost. So you'll be at the extraforaminal space, but with fields large enough, you have the opportunity theoretically to activate the dorsal root ganglion. And we show cases of covering long bone diseases. So using this case shown here for fibrous dysplasia of the humerus, we're targeting the brachial plexus at the infraclavicular level. We've done clever things higher up to C, as high as I've gone to C7, try to cover different parts of the body for postherpetic neuralgias, active cancer, and other cancer pain syndromes. And then we use the same idea for complex surgical resections and radiation. This is shown here, targeting L2 and L3, selective nerve root to cover a significant change, a resection of a sarcoma, as well as placement of a complex a hip device. But clearly we could not target the femoral nerve or sciatic nerve in this location for this surgery. And so we targeted these selective nerve roots, which have been very helpful for our population in the recent years. We have our techniques in the literature. A lot of those are done by the colleagues across around the globe, just talking about how we can implement different techniques for different nerves of the body, published last year. And so just to bring in conclusion, our data is not as robust as spinal cord stimulator data, but we are having efforts in randomized controlled trials to achieve this. But you're seeing some novel, clever devices that are really less invasive to compare to spinal cord stimulators and maybe even intrathecal pumps. This might be more useful to our colleagues around the world for depending on the devices you have available as a result. I want to thank you very much. I wasn't sure how much time I was allotted. I hope everyone is safe and sound and that we'll get to be in person, meet each other and greet each other shortly. Thank you.